So a long time ago in 2020, we developed a study, Pomalidomide Dexamethasone. Back in the old time, we thought a doublet regimen would be active and safe and convenient in high-risk multiple myeloma. We were quite disappointed with the results of Pomalidomide Dexamethasone. Quite obvious today, but in the old time it was not that necessarily obvious, particularly in these translocation for 14 patients, a subset of myeloma patients whom they had a very poor progression for survival, time to progression on Pomalidomide Dexamethasone. The deletion 17p, another high-risk myeloma subset in the relapse setting on Pomalidomide, seems to be faring slightly better, approximately 7 months median PFS, but globally it was very disappointing. So we thought it would be of interest to go on a triplet-based regimen, because we learned since then that triplet-based regimens are very important, and now we even go up to 4 drugs-based regimens. But when we started that study, triplet-based regimen, and we also figured out that one of the problems of the patients in the relapse setting, and a problem that particularly would affect the high-risk myeloma patients, is that the safety profile is often not that great, and the patients have to either taper down the dose or stop the treatment temporarily or permanently. And then the myeloma relapse, particularly for high-risk myeloma, because you have to continue the treatment with this type of drugs. So we thought to put together a regimen that would be efficacious, but most importantly, safe and convenient. So if the patient were responding, they would be having a very safe, tolerable profile, and therefore a very prolonged treatment. And so we went back to the same population, high risk, relapsed refractory myeloma, translocation for 14 and or deletion 17p. And then we gave Pomalidomide Dexamethasone plus Ixazomib, a proteasome inhibitor, oral, so convenient, safe enough, only one, so twice a week at 3 milligrams, and then once a week at 4 milligrams, so quite safe. So we first validated the fact that it was safe. We then validated the fact that because it was safe for the patient responding, it was quite convenient, and the patient were happy on this entirely oral triplet-based regimen. And then we looked at the data. So efficacy-wise, we have 2 groups, translocation for 14 and deletion 17p. We cannot study the 2 groups separately. But overall, we have made some slight improvement compared to 2010-02 study. So the global median PFS should be around 9 to 12 months, so slightly less than a year, which is disappointing, but we know, globally it's a bit disappointing, but we know that this population is very hard to treat. And we still have patients on treatment for largely more than a year. And so we believe that even if the median PFS is below 1 year, and we are slightly disappointed about that, globally there are clearly some patients, and maybe particularly translocation for 14 patients, that did immensely benefit from this regimen. And that's our the perspective, our next task is to look at these patients, understand who are these patients, because we believe that at least for those patients, this regimen might be very helpful and very useful.